start recording. I'm going to share my screen here. We're going to go to view. Okay, you guys able to see that?
Yes.
Okay, perfect. So your exam 2 will be over weeks 4 and weeks 5 materials. So chapter 21, 23, and 24. To start the review though, we're going to touch base on some vocabulary. So make sure you guys know this vocabulary, okay? Know the differences between sepsis, bacterial, viral, fungal, and all of the things listed on this page, okay? So make sure you're doing that for the exam. We're going to start with, once again, reviewing the theorist. Now, theorist-specific questions will not be on the exam, but to answer some of the questions, you will have to understand the theorist and what stage of development and all of that the kids are in. Okay, so it's not going to ask you, okay, a 2-year-old, what stage of Freud are they, you know, based on Freud's psychosexual developmental theory, what stage are they in? So you're not going to have questions like that, but it's going to be important that you understand the foundation and the concepts of these theorists to be able to be successful on your next exam, okay? So Freud, he is the psychosexual theorist, okay? So the oral stage is 0 to 1. Kids are learning about their environment through their mouth by tasting, sucking, eating, putting things in their mouth. Okay. Anal stage is ages 2 to 3, so toddler age group. Think about these 2 to 3-year-olds are learning to potty train. So they're learning how to hold their bowel and their bladder and work on successfully potty training. Phallic stage, those are preschool age kids, so 3 to 6-year-olds. Boys are more attracted to their mother and girls are more attracted to their dads during this age group. So child attracted to the opposite sex parent. Latency stage is school age, so 6 to puberty, which you could put that as 12 years of age or so. So they're more interested in spending time with same-sex peers, is latency stage. Genital stage is puberty and beyond, and those kids, according to Freud, should be more interested in and attracted to the opposite sex peers. Okay. Questions on Freud? No? Okay, we'll go on. All right. So Freud's stage of orality means that the infant's exploring the world through their mouth, right? So what's some examples of oral stage according to Freud? I kind of already gave you guys one, but.
Pacifier or bottle feeding.
Mm-hmm. Or breastfeeding too would be in that same category. Mm-hmm. Good.
Breastfeeding?
Yep. Yep. So anality, that coordinates with the toddler stage, which they're learning give and take and exercising power and no, right? But they're also learning power or potty training, which is their sense of control over their bowel and their bladder. Okay. Phallic or oedipal stage, which I have not seen that specific stage on like HESI or on exams, that name of that stage, but it's another way to say phallic stage that Freud has acknowledged. That corresponds to preschool age where they're becoming aware of their sexual being, right? So preschool age group kids, remember this might be where you see normal, appropriate exploration of their bodies in the form of masturbation and things. Okay. Latency is school age children. So that's.
Excuse me. I have a question.
Uh-huh.
In phallic stage, you mentioned of masturbation.
Uh-huh.
Because a friend of mine years ago, her son was in phallic stage, if I visited her, I will observe that the son is doing
Mhm.
masturbation. So is
Mhm.
it a normal thing to do? Is it
So,
normal?
I mean, usually you want to try to ignore it because it seems that the more you bring attention to it, the more that it's done. But the other thing to talk with that child about is making sure that they know that, and the parents about that they know that that's a normal progression of development for some kids, and that they, as the child, know that that should be done in private. Okay. And not around a bunch of people, like at school or something.
Okay.
Yep. So Freud and latency, their school age kids are focused on peer relationships and kind of learning what groups they're going to fall in when they get through puberty. Piaget, she's the cognitive theorist. Okay. Sensory motor stage is from 0 to 2 years of age. So they're learning object permanence. That was when you put a toy down in front of them and cover it up with a blanket. They know that that toy still exists. Okay. So they're trying to move the blanket to get to that toy. Prior to them developing object permanence, which happens usually around 8 to 10 months, they think that that toy has disappeared. Okay. They're curious about the world, so they're interacting with utilizing their senses. Okay. Pre-operational, this is 2 to 7 year olds. They're having symbolic thinking, so they think in symbols versus like concrete kind of things. Abstract thoughts are still difficult, and this is when you see that conservation developed. And remember, conservation was you have 2 cups. They're the exact same amount of cups, but they're 2 different shapes. So one might be shorter and more wide, and the other one's taller and more skinny, but they both contain the same amount of fluid. So kids will start understanding that in pre-operations. Prior to pre-operations, they think that, the tall, skinny one has a lot more in it. Concrete operations, this is your school age kids, so 7 to 11 year olds. They are understanding time and space and quantity of things, and can apply to kind of some basic concrete situations, but they don't have the abstract thought. So they don't have like what if thoughts or hypothetical situations. Okay. Formal operations is 11 and up. So this is going to be your adolescents, late school age adolescents. So these kids are having abstract logic. They can understand some reasoning. They're thinking of pros and cons of things. They're thinking of hypothetical situations, like what if this happens versus this happens. Okay. Questions on Piaget? No. Okay. So breaking down Piaget further. So object permanence, we already kind of talked about that, so I'm not going to go back into that further. Symbolic thought, so they're thinking about how it appears rather than being logical. So sorting blocks by color, not by size and shape. Animism, remember that's when we're giving non-living objects human feelings. So our teddy bear is a human and has feelings. Okay. Concrete operations, this is logical thinking, understanding cause and effect. If I get sick, why did I get sick? Why did my dog die? They kind of blame themselves. Thinking, trying to start to connect the dots with thinking logically, but still very basic. Okay. Formal operations, this is your adolescent age group, 11 to 16 years of age. So this is developing that abstract thinking and moral reasoning. Okay. Erikson psychosocial development. So here's your age groups. And each crisis. So infants, trust versus mistrust. They cry, they get fed. They cry, they have their diaper changed. They cry, they have their needs met. If they're crying and crying and crying and parents are not caring for that child, then they're going to be stuck in mistrust. Okay. 18 to 3-year-olds, autonomy versus shame and doubt. So this is that toddlerhood age group. So they want to do things themselves. And if they're not allowed to kind of develop their own little personality and be able to do some things for themselves, then they'll feel shame and doubt. Okay. 3 to 5-year-olds, these are preschool, initiative versus guilt. So they're trying to find a purpose by taking initiative and doing the tests that they're asked. Learning how to sit in preschool environments and things like that. 5 to 13-year-olds, so school-age kids, industry versus inferiority. They're getting really industrious, really competent in doing their schoolwork and doing what's asked and starting to interact with other kids. And if they're not allowed to be industrious, then they feel inferior. So their self-esteem will be negatively impacted. And then the last one for pediatrics is identity versus role confusion. So this is adolescence, so 13 to 21. This is where they're figuring out where they're going to fit in their school groups, in their social groups, their relationships, what they're going to do when they are done with high school and developing relationships. So infants are in the stage of trust versus mistrust. They have to develop a sense of trust. And then that's helpful in continuing to develop their personality. Toddlers are shame and doubt, so they should be potty training, they should be self-feeding, they should be dressing themselves, they should be learning to express their needs. If they are not doing those things, then they're going to have doubt and shame. Okay. Preschoolers are initiative versus guilt, so they should be, caring for pets or feeling like they can nurture things, whether that's their dolls or their pets or, accomplishing small tasks that they're asked to do. And if they do not accomplish those tasks or they're maybe neglecting, they might feel guilty. Okay. School-age kids and industry versus inferiority. This is developing new tasks like teamwork and competitive sports, and then recognizing their accomplishments. Adolescents, identity versus role confusion. This is they're trying to figure out their definition of self, improving their self-esteem, and then making appropriate, life decisions on where they're going to have their careers lead. Okay, Maslow's hierarchy of needs. So the red is physiological needs. So that's what you need for your body to function. So food, water, hydration, sleep, urinating, safety. Okay. Next one is safety needs. So protection, so a home, secure, family. Okay. And they have to have the basics to be able to kind of step to the next category. Next one is love and belonging. So feeling like they have activity, they are cared for by their parents, they belong in their school system, they belong at home. The next category is their esteem. So like self-esteem, their sense of accomplishment. And then finally, their self-actualization. So that is where they feel that they are going to fit. Okay, in the world. Like I said, it's a hierarchy. So you have to have needs met, basic needs met to kind of move through the next category. Okay, Kohlberg is the moral theorist. So omnipotence or punishment is infancy. Okay, that's the first stage. There's no difference between doing right and wrong and avoiding punishment. So they don't understand that, with them making a poor choice, that they're being punished because they made that poor choice. They just understand that they're being punished. Okay. Self-interest. This is preschool. So interest shifts from rewards rather than punishment. So preschool age kids, you want to try to motivate them with a reward system to accomplish what, they're trying to accomplish, like potty training. Conformity and interpersonal accord. This is school age kids. So this is the good boy, good girl level. So they're trying to meet the approval and maintain friendly relationships with other people. Authority and social order. This is also school age kids. So their orientation to fixed rules, their understanding, here are the rules. This is what we have to do to play this game and to accomplish this game and to win this game. And by them understanding fixed rules, they're understanding morality. So, lying and cheating and things like that, they're really focused on not doing those things. So that way they can continue to maintain a good interpersonal relationship with their peers. Social contracts. So this is teens. So this is mutual benefit. So teens understand the morally right and wrong, and legally, right and wrong are different. So something may be illegal that they feel is moral, or the more moral choice. Okay. And they also believe that utilitarian rules, so like one all be all kind of rules make life better for everyone. So one rule across the board with no exceptions. Okay. That was kind of our review of things for the prior exam. Like I said, that you may continue to need to answer questions going forward on exams. Okay. Now we're going to talk about chapter 21, which is the hospitalized child. So, in looking at these, I'm not going to go into all of these. Knowing when hospital discharge planning starts, that's right as soon as they're admitted. You should be looking towards discharge with adults, but also children. Talking with different age groups, or looking at different age groups, choosing age-appropriate play activities or interactions with other kids in the hospital to try to maintain that social relationship. Also encouraging parents to stay to help lessen the child's separation anxiety and anxiety around their care. Okay. Reassuring parents of what's going on, letting them know, and being in communication with them as a nurse is really important. Okay. Obviously doing all your assessment skills. So if you have a kiddo that is having low levels of consciousness or altered levels of consciousness, noticing that their vitals might be trending differently, their blood pressure might be starting to drop or something like that, is important when you're caring for a hospitalized child. Looking at how you're going to assess that kiddo. So listening to their heart sounds and their lung sounds, while they're sleeping or while they're on their parent's lap might be more beneficial for an accurate reading of their vitals in your assessment versus, having the parent hand them to you or put them in the crib for you to listen to them. And then the child gets really worked up and starts crying and fighting while you're trying to listen to them. Your vitals aren't going to be accurate that way. So trying to keep those kiddos in their most comfortable position so that way you as the nurse can assess them in the most appropriate way. Okay. Separation anxiety, it begins at 6 months age and peaks at 10 months of age. And then you also see it start again around 15 months of age and peaking again around toddlerhood or around like 18 to 20 months of age. So the stages are protest. So toddlers may watch and listen for their parents. Their cry is continuous until they fall asleep in exhaustion. So, some things that you can do to combat the protest stage of separation anxiety is having caregivers be consistent, short goodbye rituals. They're not really prolonged, of saying goodbye, 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 and coming back for, 10 hugs and kisses before they leave. Okay. Distraction, reassuring that child that that caregiver will be back, after lunch or later in the day when they're coming back. Despair is the next stage. So children appear sad or depressed. They may withdraw from strangers who approach. They do not want to play actively with their toys or with others. So ways that you can combat the despair piece is familiar objects, avoiding times when the child, avoid doing things with the child when they're very hungry or very tired, and then talk about something fun that might happen when their parents come back. Okay, the final stage is denial or detachment. So when you see those, you kind of know that they both mean the same stage. So children will deny their need or become detached from that parent or disinterested if they come back to visit. This is a form of coping mechanism to reduce the emotional pain that they're going through from the separation anxiety. Okay, they're more interested in playing with their toys or others than their parents. So to combat this, you should assist in rebuilding the relationships of the child. So if the child starts having outbursts or refusing to, spend time with the parents, when they return, explain to the parents that that is not an uncommon thing, and that it's not their fault. It's just kind of the process of separation anxiety that child's going through while they're hospitalized. Encouraging parents to stay there if they can, so then that child realizes that they don't have to any longer have that denial or kind of have that wall up with their parent. Pain scales. So ages 3+, we should be able to do the faces, okay? So in doing the faces scale, you usually say, okay, show me which picture is your pain right now, is your hurt. What picture are you? And then they'll point. If they're less than 3 or they're nonverbal, then you'll use the FLAC scale, which looks at the different categories of face, legs, activity, cry, and consolubility. Okay, so there's those. Types of pain management. So pain management, or pain is your 5th vital sign. So while you're doing your assessments, you should be looking at pain. It's whatever the client says it is, and wherever the client says the pain is what pain is, okay? Tylenol is or acetaminophen is for mild to moderate pain. Ibuprofen or Motrin can also go in this factor. But what you're going to see more utilized is the acetaminophen or Tylenol, okay? The most effective pain relief strategy is low dose analgesics around the clock on a regular schedule rather than waiting for that kiddo to call and say that they're in pain. Because a lot of times kids don't like the taste of pain medication, so they'll wait until the very, very last second until they can't take it anymore, and then their pain is way out of control, okay? Opiates are used to treat moderate to severe pain, so post-op pain, sickle cell pain, cancer pains, things like that. Lidocaine is a topical anesthetic, so that's used for IV placement, or so you'll see like a topical, like a lidocaine cream, a numbing cream that's put on prior to labs or IV placement or sutures. Conscious sedation is when they impair the child's consciousness, but the child can continue to maintain their airway and respond. So that's when they might use something like intranasal Versed. Okay, eyes. So pink eye or conjunctivitis is inflammation of the mucous membranes around the eyelid. Okay, they're going to have scleral injunctiva or injection. which is redness of the sclera, which is the whites of the eyes. Pink eye and conjunctivitis is very common in daycare settings. It can be bacterial, viral, or allergic. When you have that goop that, parents wipe away and it starts coming right back, that's usually more bacterial driven. That starts in both eyes and they've had nasal congestion and things like that, you are more concerned about viral causes. Okay. Hyperopia, that's farsightedness. So that means that they can see well up close, but they have a hard time seeing far away. Myopia is nearsightedness, which means they can see really good far away, but they cannot see well close. Amblyopia is the lazy eye. So this picture here is showing patching. So his lazy eye is having to work harder because it's unpatched. So they're forcing those muscles of that lazy eye to start working by patching the good eye. Strabismus is the child's eyes cannot both move towards the same object. And there's different forms of strabismus based on where their eye drift goes. Nystagmus is constant jerking movements of the eyeballs. They can be horizontal or vertical or rotary. Papilledema is edema of the optic nerve. And that can be a sign of increased intracranial pressure. Okay. Or something that you may see with like a brain tumor. Okay, ears. So types of hearing loss, know these. Congenital hearing loss is baby is born with it, or it comes from an intrauterine infection, or it may be hereditary, but baby is born with congenital hearing loss. Sensory neural hearing loss, that comes along from there's damage to either the cilia, so the hairs in the cochlea, or the acoustic nerve being damaged. Okay. Conductive hearing loss, that happens when the tympanic membrane itself prevents sound from entering the middle ear. So they have a bunch of earwax in their ear canal, or they have an ear infection, so that sound can't bounce off and enter the middle ear like it needs to. Okay. When caring for hearing impaired children, make sure you're face to face with that child, your eye level. You're establishing eye contact and you're talking in short sentences. You're not trying to like over exaggerate your lip movements or your facial expressions. Otitis externa is an infection of the external ear canal. So with that, we treat with antibiotic ear drops. Okay. Otitis media, so that's an infection behind the TM, so in that middle eardrum. If they do not have ear tubes or a perforation, eardrops will not get there, so they need an oral antibiotic. Okay. There can also be viral ear infections, from viral illnesses, but you still treat as if they're bacterial because of the risk of hearing complications if they're not treated. Okay. All right. Next is seizure disorders. So a seizure is a burst of uncontrolled electrical activity between the brain, and then that causes abnormality in movements or tone or behaviors or sensations or states of awareness. Okay. There's different types of seizures. So grand mal or general is generalized tonic-clonic muscle jerking. You're going to see shallow, irregular breathing and potentially loss of bowel or bladder control. Okay. These kids will also then have a post-ictal state, which is where they're confused and they're very, very fatigued and sleepy. Okay. petit mal or absent seizures. This is where they are staring off for a few seconds, maybe up to 30 seconds. And then when they stop staring off, they're right back focused on whatever was happening, as if they didn't have that staring spell. Okay. Jacksonians are simple partial seizures. So this is one area of the body it starts. So like maybe an arm starts twitching, and then it can move to, more progressive jerking, but the person's awake and aware at all times. So frequent eye blinking, mouth opening, things like that can be simple partial seizures or Jacksonian seizures. Myoclonic spasms or atonic seizures. This is those drop seizures. So they'll have sudden jerking movements or twitching movements, and then all of a sudden they collapse. Usually they come back to within about a minute. Status epilepticus. This is when there's prolonged seizure and it's not responding to treatments for 30 minutes or more. Okay. And postictal period. So with all those partial seizures, you don't have postictal periods usually. It's mostly just with the grand mal or the generalized tonic-clonic generalized seizures, okay? Okay, what can cause seizures? Infections, fevers, drugs, an epileptic disorder, so a diagnosis of epilepsy, or low blood sugar, hypoglycemia. So any of those things can cause seizures. As far as your precautions as a nurse, if that child's hospitalized, their bed rails are going to have padding on them, okay? So if that child were to start seizing, they're not hitting their head or their body against those hard pads or the hard bed rails. They're going to hit against pads instead. Removing all sharp objects or hard objects, okay? Having suction set up and ready, because those children who have seizures, especially generalized seizures, there's a likelihood that they may, as they're coming back to, not be breathing well. So they might need suctioned. Having parents have that child wear a medical bracelet or band that says that they have a seizure disorder. So that way, if they're out somewhere in public and parents aren't right there by them and they start having a seizure, someone can tell that they have that diagnosis. Teaching the parents importance of giving those medications regularly and at the exact same time of day. Or, if they have a seizure that's prolonged, that they have a medication that they need to give that child, teaching them how to utilize that as well. Also, safety-wise, if kids have seizures, they probably shouldn't be driving vehicles, right, of any sort. Probably need to be really careful about swimming because they're going to be more at risk for drowning, because what if they get overstimulated during swimming and they start having a seizure? Okay. So just talking with parents about those increased risks for hazardous activities. That doesn't mean you're telling parents to keep their kiddo in a bubble and not let them do anything, that other kids do, but just that they need to be extra cautious with those things. Okay. And the medication depends on controlling the seizures with the least amount of side effects. Okay. Meningitis is inflammation in the covering of the brain and spinal cord, the meninges of the brain. Okay. So it's typically caused by Haemophilus influenza type B, which we give a vaccine for, multiple vaccines, in early infancy. And since doing this, we haven't seen meningitis happen as often in infants. Petechiae, if you're noticing petechiae on an exam, you're more suspicious of meningitis being the cause of the infection. Okay. If it's bacterial, it's because of the pus causing a lot of toxins as it is released in the meninges of the brain. Okay. Treatment, these kids are put into droplet isolation until after 24 hours of their antibiotics. Okay. So kids, even if they're pretty suspicious that it's a viral type of meningitis, kids that have been diagnosed with meningitis, almost all of them will get 24 hours of antibiotics because of the risk of bacterial meningitis being missed and causing death very soon after diagnosis. That's pretty standard that everybody gets 24 hours of antibiotics. Neurovascular checks and neurologic checks will be ordered, so you'll be doing those frequently. You want to make sure if there's some weakness in the limbs or speech difficulties or altered mental status or behavioral issues all of a sudden, that you'd be reporting those as abnormals. Okay. Maintaining very accurate vital signs and intake and output is really important because you get concerned about intracranial pressure and sepsis. Okay. And not having these kids have a lot of visitors that are overstimulating can be helpful in recovery as well. Okay, now we're going to go on to fractures. Okay, any questions about neurological stuff before we move on? And remember, encephalitis is inflammation of the brain. Meningitis is inflammation of the meninges of the brain. And then encephalomyelitis is inflammation of the brain tissue and the spinal cord. Okay. All right. Any questions? No? Okay. All right. Different types of fractures. So there's fractures, there's sprains, there's strains. Fractures are breaks. There's you might also hear them called like stress fractures. It's still a fracture. A stress fracture is still a fracture. Okay. So fracture is a break. A green stick fracture is an incomplete break where one side of the bone is broken and the other is just bent slightly. Okay. A compound fracture is when there is a broken bone that comes outside of the skin. So breaks that wound open of the skin, that skin barrier. And you get more worried with compound fractures of not only compartment syndrome, but also infection because of that opening, that open wound in the skin from the fracture. Oblique fracture is a complete fracture that's at an angle. So that fracture is going to go, that break is going to go clear through the bone and it's going to be at an angle. Spiral fracture is from a forceful twisting movement. It's usually most commonly found in the femur, and if it's found in the femur, that's more suspicious of child abuse. Okay. So if you see someone with a spiral fracture and it's a kiddo who can walk around and can potentially get a spiral fracture, but the parents' stories are different, or the parents and the child's stories are different, or they start out with this story and then we kind of add, some different layers to the story, I would still be suspicious that that kiddo maybe got that injury from abuse. Of course, if the child's not ambulatory, they're not walking around, they're not really moving a whole lot, and they have a spiral fracture, that would be very indicative of abuse. Okay. A sprain, that's where the ligament is torn or stretched away from the bone at the point of trauma. So this will usually, you'll see, swelling and damage to vessels and muscles and nerves. A strain is a tiny tear to the muscle or the tendon that occurs over time. So like when kids roll their ankles, it's most of the time, and they have swelling and pain for a period of time and then it gets better. That's usually a strain that's happening. Okay. Strains are with tendons, usually, and sprains are with ligaments. That's kind of your difference. Contusion, so that's bruising. Okay, so tearing of the subacute tissue that results in hemorrhaging, edema, and pain. So you're going to notice a lot of bruising, they're going to have discomfort, and they're going to have swelling if they have a contusion. Okay, here's your pictures for fractures too, if you're a person who benefits from pictures. Okay, so you can see the oblique is, you know, at an angle. This would be like a compound fracture if it was poking through the skin. Okay, convoluted, so that means there's a fracture and then those bone pieces have broken down into tiny little pieces of bone. So that's a convoluted fracture. And here you can see the green stick fracture, where there's one more linear fracture and then the bone is kind of bent up. So that's what a green stick fracture looks like. Okay. Okay, bone issues. So scoliosis, that's curvature of the spine. So one shoulder usually is more prominent than the other shoulder. Your arms might appear like one side's longer than the other. And you want to have them put feet together and bend over at their hips or their waist, let their arms hang, and then look for asymmetry in their back. Okay. Ewing's is a type of sarcoma, so that means it occurs in the marrow of the bones, typically long bones like femur. Okay, so that's going to be a tumor that starts in the marrow of the bone. Lakeheath-Perth's, so this is a disruption of the end of the bone development of the head of the femur. So kids with Lakeheath-Perth's, they're going to have a bunch of teeny tiny little fractures at their head of their femur that eventually, if it continues, it will become necrotic because those vessels in that area are no longer feeding that bone. Okay. JIA, or juvenile idiopathic arthritis. JRA used to be what it was called, juvenile rheumatoid arthritis, same thing, okay? It's a systemic, so generalized body autoimmune disease, okay? You're gonna see inflammation in the joints, multiple joints, usually knees, ankles, hips, back, wrists, finger joints, feet. They're also going to have issues with their connective tissue and their viscera. So they'll have stomach complaints sometimes, joint complaints. When their JIA is flared up, a lot of times you will see redness, irritation, swelling in those joints as well. 4 or less joints are typically affected for it to be JIA. Osteosarcoma is a primary malignant tumor of the long bones. So this is where you'll see the amputations potentially done. And like I said, long bones, so femur is most common. They'll amputate that, cut out that femur, and then reattach their tibia and fibula in their foot, usually, to where their femur would connect into their hip or their pelvis. And then that way that kiddo can have a prosthesis. Duchenne's muscular dystrophy is one of the most common forms of muscular dystrophy. It only occurs in boys. Okay, and it's a progressive muscle deterioration. So, you know, they may start with being somewhat developmentally appropriate and getting some fine motor skills and gross motor skills down, and then all of a sudden they start to have regression in those things. The key that you'll see with kids with boys who have Duchenne's muscular dystrophy is their calf muscles are going to be really large. They're going to have hypertrophied calf muscles. Okay. Eventually their muscle weakness will progress far enough to where they're not able to maintain their respiratory status any longer. And that's usually how they die. Okay. Torticollis is tightness in the shortening of the SMC muscle, so sternocleidomastoid muscle. So you're going to kind of see those kids, those babies especially, that really favor one side and they can't turn the opposite side. A lot of times with torticollis too, you see plagiocephaly, which is that flat spot in the back of their head. Okay, Buck's traction. So this uses weights, usually preoperatively for femur fractures to prevent them from having spasms. Okay, it holds that body part in the correct alignment. Okay, and then that traction is on a pulley system with weights at the end of the bed that should be free hanging.
So I
Okay.
have a question, because this was on the Cahoots.
Mhm.
And I picked 5 and 5 was wrong. So it wasn't asking how long the weight was going to be on the baby.
So that was with Brian's traction, and that's 30 pounds or less that they'll use for Brian's traction. For Buck's traction, it's no more than 5 kilos, which is about 11 pounds of weight. Okay. It's not used to hold reduction, so it's not used to hold that fracture in place long enough to heal. It's kind of a temporary thing until they can get in and surgically fix that fracture. Okay. They can also use it for for broken arms, but that's not something I commonly see. It's mostly the leg fractures. Okay. So there's your purposes of traction. Okay, so your 5 Ps, these are with your neurovascular checks. So if somebody is in traction, you guys will be doing neurovascular checks very often. Also, if someone has a fracture and they're hospitalized for it, you will also be doing neurovascular checks, excuse me. So you'll be assessing for pain, pulse. So do they have good pulses? Pallor, so are they really white? Do they have paresthesia so they can no longer feel? Or do they have paralysis so they can no longer move that area that's affected? Okay. Pale color or cyanosis, so bluing of the fractured site distal to the fracture site, is very concerning, and it's telling you that their circulation has been compromised. So they might be progressing to compartment syndrome. So if you find anything abnormal in your 5P circulation assessments, you need to be telling those providers right away. Okay. Traction, cervical traction. So this is traction on the skull. Crutchfield is a type of like a tong used in the cervical traction. That's what's happening in this picture. And then they place the little weight under the chin to kind of keep that traction in place. And Steinman is where they actually insert a pin to that bone and put the traction from that pin. These are both forms of cervical traction. Okay, cerebral palsy or CP. So this is a group of disorders that affect movement, muscle tone, or posture, or all of those things. It's caused by damage to the immature brain. As it develops, it can happen in utero if there's an infection or something like that while mom's pregnant. It can start, or it can happen during delivery if there is a forceful delivery. They need to get that baby out, and there's some damage to the brain as they're trying to pull that baby out. Okay. Also, oxygen deprivation during pregnancy or during delivery can also relate to cerebral palsy. Okay. Symptoms you usually notice fairly soon after being born, but sometimes in some kids it takes until their preschool age to notice the symptoms of cerebral palsy. They're going to have impaired movements with abnormal reflexes. They might be more floppy. They might be more rigid. They might have kind of jerking or involuntary movements or unsteady walking or abnormal, like, they're really slumped over posture and they can't really coordinate their movements. Or they might have all of those things. They might have just some of them. Okay. Spastic CP is increased muscle tone and contracted muscles. So they're going to be really stiff and they're going to have a hard time doing coordinated movements. This is the most common type of CP, and it's almost exclusively the type of CP that you see. Okay. They may have different muscles that are spastic that are involved. Okay. Athosis is involuntary, purposeless movements that interfere with a child's normal motion. So you might see the athosis of fingers, specifically, like in this picture. Ophthalmos is the involuntary arching of the back. So it's caused from the contractions of those back muscles, and they get really arched back. Okay. Child abuse triggers. Here are the things to keep an eye out for child abuse triggers. Any of these things could potentially be placing the child more at risk for child abuse if any of these things are going on in the family. Okay. There's different forms of abuse. So emotional abuse, that's verbally destroying child self-esteem. Emotional neglect is intentionally missing or not meeting those verbal and behavioral actions with appropriate emotions. Sexual abuse, obviously that's sexual act performed on that child. Physical neglect is failure to provide their basic needs. So like, food, water, shelter, those Maslow hierarchy physiologic needs. And physical abuse, of course, is a deliberate injury. Okay, you'll need to know your dosage calculation stuff again for this exam. Okay, so weight-based, okay? So you'll need to know how to calculate pounds to kilos. So to do that, you'll just take your weight in pounds and divide it by 2.2, and that will be their weight in kilograms. Okay. In my class, I'm not sure in Professor Stahl's class, but I'm sure she provides you with this material as well. There are, under the exam review materials, there is another dosage calculation video. There's also multiple under the exam 1 review materials, along with worksheets in that area if you want to do math problems. Okay. You'll also have to calculate your milligrams per mil. Okay. And you'll have to figure all that out by the weight-based, figuring out your weight-based milligrams, and then figuring out how many milligrams your child needs versus what you have on hand. Do you want to do a practice one of those really quick?
Yes.
Yes.
Okay. So let me see. I can't remember if we have. Nope, we don't. Okay. So I'm going to, let me stop my screen share here. Okay. One classic one is, it's pretty easy. This is what I can think of a good example because I do this like every day, 500 times a day, I feel like, with my patients. Tylenol dosing, figuring out what dose of Tylenol to give a kiddo. So you have, let's say, 38-pound kiddo. So they're 38 pounds. You have to figure out how many kilos that kiddo is. So remember what I just said, we take 38 divided by 2.2. And we get 17.27. Usually I go with to the hundredths place for rounding. Okay, so 2 spots after the decimal. But pay attention on your quiz or on your exams too, because it will tell you how far to round. Okay. So we got 17.27 kilograms. Your doses for Tylenol is 15 milligrams per kilogram per dose. Okay. So how do you figure that out? 15 times your kilos, 17.27. So that's going to tell you how many milligrams is safe for that child. Okay. And you'll have all of this information from whatever your question is. I'm just giving you it. So when we take 15 milligrams times 17.27 kilograms, what do we get?
259.05
Yes, milligrams, right?
grams.
Milligrams. Don't lose track of what you're calculating. So that's how many milligrams they can have per dose. Now your liquid Tylenol comes in 160 milligrams per 5 milliliters. Okay. Now this kiddo can have 259 milligrams. So we have to figure out how to get 259 milligrams, how many mils we're going to give this kiddo. Okay. And we do that by 259.05 divided by 160, because that's what you have on hand or what you have available. So it's ordered divided by what you have on hand. Does that make sense? So 259.05 divided by 160, and you get 1.619. So I would say 1.62. Okay. And then you're going to take that times your milliliters. So you're going to take that times 5. And then you're going to get 8 mils. Did I totally confuse you guys?
No, that was fine. I was able to follow that.
Okay. Yep. So that's kind of what you'll need to know for this exam. You'll have to figure out your pounds to your kilograms, and then your milligrams or micrograms or whatever your order is per kilogram. Okay. Then you'll have to figure out if it's per dose, or, if that's your daily amount and you're doing the dosage a couple times a day, then you'll have to divide it by 2, So you'll have to figure that out based on your problem. When you figure out the amount of milligrams based off that child's weight, then you have to figure out how many mils to give that child. Okay. Do you want me to give you guys another one?
Please, ma'am, can you write it so that I can you write the question and the soft one so that I can be able to put it down, please?
Yeah, here, I'm not sure how. Let me think about how I could do that easiest. I'll pull up we're kind of going into your time. Are you okay with that?
Yes, that's fine.
Okay.
That's fine.
Okay. All right. Okay. Let me see. I'm going to go to our announcements from exam 1 and we'll practice the problem. Also, the videos are like Professor Bogart does a very, very good job explaining everything. So those videos, and there's a couple other YouTube videos that are really good about explaining things in different ways. If the way that I'm explaining it isn't like you're having a hard time understanding it. So I would not be afraid at all for you guys to use those videos to kind of go through the breakdowns a little bit further. I'm gonna go, let's go here. Okay, I'm gonna share my screen and we're just gonna do this first one as an example, okay? So this first question. So a client is prescribed ampicillin 200 milligrams by mouth every 6 hours for tonsillitis. Ampicillin is prescribed in 120 milligrams per mil. So you're trying to figure out how many mils you're going to do per dose. Okay.
Okay, perfect. So for something like this, we know we're doing 200 mg every 6 hours, so that would be 4 times. Are we doing 800 divided into 125? I feel like that's where I mess up.
No, because it's asking you per dose. So your per dose amount of milligrams is 200 milligrams, right? Because that's what you're giving each dose. If it was asking a per 24 hours or per daily amount, then that's when you would have to figure out, you know, how, okay, you're doing it 4 times a day. So your daily amounts can be 800 milligrams, right? So right now it's just asking you per dose.
Oh, so it's just 200 divided into 125. Oh, so maybe I'm just not reading it right.
You're making it too complicated. And that's not an uncommon thing in students. You get very overwhelmed by all those numbers thrown at you and you're like, oh crap, I don't know where to start. So all you're going to do in this scenario is your 200 divided by 125, and you're going to get 1.6, and it's telling you to round to the nearest whole number. So you would round up to 2 mils. Now, say it was 125 per 5 mils was your dose. So you'd have to take it a step further.
So then 200 divided into 125 times 5.
Yeah, and then that answer times 5. So the 1.6 times 5, and then that would get you your 8 mils if it was another dose, or if it was another availability. So 125 by 5. Okay. So let's do this number 3. So the child's 28 pounds, and your theophylline dose is 2 micrograms per kilogram. So you're going to have to figure out your pounds to kilos. Figure out your pounds to kilos and then tell me what you got.
$25.45.
Is that your, how many kilograms did you get? That's all that I'm asking for first here.
Okay.
28 divided by 2.2. 12.72 repeat.
Yep. So we can do 12.73, just call it 12.73. But I will tell you, while you're doing your calculations on your computer, just leave it as the repeating number, okay? Just leave it there. Don't do any rounding until the very end. Okay? So then we're doing micrograms per kilogram. So then we're taking the 12.72 repeating times 2 micrograms.
25.44.
Yep. And so now it's not telling you to round to the whole number, but so then you would round, you know, 25.5. micrograms is going to be your dose.
I have
Okay.
a question, please.
Uh-huh.
In this math, the answer is 25.5. If they didn't ask us to round, am I going to round it to 25.5? If they didn't ask us to round?
Well, it didn't ask you to round, but on your exam, it'll ask you to round to
Okay.
whatever space. It should.
Okay.
If it doesn't ask you to round, then usually there's multiple answers accepted, like rounding to the 10th place, rounding to the 100th place.
Okay.
Yeah. But if you put in 25.5 as your answer, then that's correct. If that's correct, then it would be accepted. Unless it says, round to the 100th, then you'd want to put 25.45 or 0.46 or what have you. Okay. Questions on that?
No question.
Okay. Anything else you guys want to do? No? Feeling confident? Okay. Alrighty. So I'll stop this and then I'll just rejoin, okay? Then we can talk about our questions.
Okay.
Okay. Thank you.